Hello everyone, good afternoon. Thank you for joining for today's webinar. My name is Miss Anahima Thomas and I am working as an assistant professor at MGM New Bombay College of Nursing. I will be the moderator for today. We are presenting the webinar on the topic Management of Children with COVID-19. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the chat box or the question pane in your control panel. I will bring them up at the end of today's presentation and we will also have time for question and answer session at the end. For your kind attention, please mute yourself in the Zoom meet before proceeding with the webinar. Now, with further ado, it's the time to take over to Mrs. Preeti Maria Matthew, Associate Professor, MGM New Bombay College of Nursing, for delivering the welcome address.
Good afternoon to all. Resource person, senior and junior faculty members, delegates, nursing professionals, and students. It's my proud privilege to welcome all of you for this 2 days webinar on the management of children with COVID-19. MGM New Bombay College of Nursing organizing this webinar in collaboration with Department of Pediatrics, MGM Medical College Hospital. I take this opportunity to welcome Dr. Prabhakar Dasila, Professor and Director, MGM New Bombay College of Nursing, for encouraging us to organize this webinar for our nursing professionals. It's my honor and privilege to welcome Dr. Vijay Kamale Sir, HOD and Professor, Department of Pediatrics, MGM Medical College Hospital, for coordinating with us and for planning this 2 days of webinar. I take this opportunity to welcome today's resource person, Dr. Jitendra Gawani, Professor and PICU in charge, Dr. Revati N, Associate Professor, Dr. Suhat Karche, Assistant Professor. All these doctors are from the Department of Pediatrics, MGM Medical College Hospital. They'll be deliberating regarding the various category and severities of COVID-19 and its management and the psychological issues during COVID-19. Day 2, we have the speakers like Dr. Kamale Sir, Dr. Suhas Karche, Assistant Professor, Dr. Prakruti KD, Assistant Professor, Dr. Amol A, Senior Assistant Professor, Dr. Krishna B, and Dr. Priyanka A, Senior Residents. These are all from the Department of Pediatric, MG Medical College Hospital, who will be talking on preparation for management of children with COVID-19, various devices and equipments, various common drugs which are used and drug calculation. We also have Dr. Sindhu Thomas, Assistant Professor, MGM New Bombay College of Nursing, Dr. Padmaja Davale, Associate Professor and Nursing Superintendent, MGM Medical College Hospital, who will be deliberating regarding the nutritional management in COVID-19 and the nursing management of critically ill children with COVID-19. For this 2 days webinar, I welcome you all. It's my privilege to welcome all the senior and junior faculty members, all the nursing professionals, delegates, students, and various other faculties for this 2 days webinar. WHO has declared COVID-19 as a public health emergency and subsequently declared it as a pandemic. And this COVID pandemic has made a catastrophic effect on the global health. Earlier, it is well documented that the children are less commonly affected with this, and majority are remaining asymptomatic. Only 1 to 3% of the cases, they need intensive care admission. But recent incidences, evidences, as well as the studies suggest that there is a substantial rise in the numbers, both national and international level. Hence, it is mandatory to recognize and prepare the hospitals and healthcare professionals, especially the professional nurses, to manage the children with COVID-19. Professional nurses need to be continually motivated to broaden their knowledge so as to engage themselves in caring these children, preventing the complications and managing the critically ill children with COVID-19. For this reason, keep in mind, we have organized this 2 days webinar to create awareness regarding the management of children with COVID-19. With this, I conclude this welcome speech and hand over the mic to the moderator.
We can start with the first session. The first session is all about the introduction related to the management of COVID-19 in children. So I would like to call Dr. Vijay Kamale sir, HOD Department of Pediatrics, MG Medical College Hospital, Kamote, and he is also a member in pediatric COVID-19 task force. So I welcome you, sir, for delivering the session.
Thank you, Department of Nursing College, and all the people. Thank you, Dean sir, also for allowing us to carry out this program. Everybody knows that COVID is increasing, second wave is probably decreasing, but there is a possible chance of third wave. So in view of that and a possibility of children being affected more, there is a possibility we have to arrange such a program. Children, as you know, are different than the adult. The management is multidisciplinary, so knowledge is important, and dissemination of knowledge will give to all the people, not only medical, paramedical, ward boys, etc. It is important. So regarding that, this webinar has been arranged by MGMIHS. It is known till now that children are less commonly affected with this COVID infection, and majority of them are asymptomatic or mildly symptomatic. But whether this notion will hold true or no, that time only will tell. Everybody knows a small proportion of symptomatic children may need hospitalization. So 10 to 20% children may need hospitalization, and 1 to 3% of symptomatic children may have severe illness requiring intensive care admissions. Regarding this is very important, why children will need tests and why they should be isolated, and if a child is come for a fever, everybody says no, we'll keep the child at home, and other thing is there is no need of testing. But if that child is positive, he will spread infection to others, and there will be vulnerable people like older persons or people with immunodeficiency like diabetes, and that will be dangerous for them. So that is why the diagnosis of childhood COVID infection is very, very important. You cannot tell that the parents, no, there is no need of test. So test is very, very important, because as said, even here median incubation period of is 5.1 days, and as per current evidence, the period of infectivity starts 2 days prior to onset of symptoms and lasts up to 8 to 10 days. So if the child gets fever before 2 days is probably infective, and that is very important part to be noticed and to be stressed to the parents regarding counseling of the test. So each and every child of suspected flu-like illness need to be tested.
अरे बट मैम नेट नहीं है ना, बैकअप है यहाँ पे बट नेट नहीं है. वो वेबकैम हम निकाल के इधर भी लगा सकते हैं.
Hello, please mute yourself whoever is talking. So we know the pathophysiology of adults. In adults, it is known that it is similar to that. Almost 80 to 90% will be mild symptomatic, 10 to 20% will be severe. And see, what is severity? Severity in adults is measured in the form of acute respiratory distress syndrome, sepsis or septic shock, multi-organ failure, including acute kidney injury, acute cardiac injury, and there are post-COVID complications also. This we have experienced till now. First wave, second wave, MGM was the stalwart in managing the patient. Almost 6,000 patients we have managed in MGM till now during in first and second wave, and we have faced all the nurses, paramedical people, doctors have faced these problems, but whether they will be common in children, that time will only tell. There are certain things, that is autopsy findings in China, European countries have showed that there is an endothelial damage, pulmonary vasculature, microvascular thrombosis, hemorrhage linked to extensive alveolar and interstitial inflammation, and which will ultimately result in pulmonary intravascular coagulopathy and hypercoagulopathy. And this will lead to impaired ventilations, perfusion ratios, acute respiratory distress syndrome again. But in children, limited data is available because till now in children are not affected much. But what is coming is MISC. This MISC will be talked by the stalwarts like Dr. Jitendra, who is a task force member of Maharashtra government. In detail, I'll be just giving you the introduction. But in children, presentation is quite different. It comes in two forms, acute COVID and MISC. So that is why the evaluation strategies need to be modified, and that is why pediatric task forces have been formed. MISC is a serious post-COVID complication and has to be dealt with caution. Again, I will stress that a clinical presentation of MISC is like flu-like only, like COVID only. So a given case, you have to differentiate a simple flu, a COVID-like illness, or a MISC. What are prediction about possible third wave? India's epidemiologists have given very clear indications that third wave of COVID is inevitable, and it is likely to start from September to October. But today's news is that it can be started within 2 to 3 weeks also. So nobody is sure when it will start or whether it will start, because few experts predict that wave will not affect much a pediatric population. But we cannot blame anybody, or we cannot go by this study, because all the waves have come suddenly in India because of various factors. So the preparation of COVID should be completed to deal with the third wave of COVID-19, which is expected to affect younger population. There are certain new things about strains. New strains are coming and they are changing frequently. Pathogenicity of new strains is unpredictable. That is why we have to prepare. I will share you our MGM data regarding COVID illness. Is in first wave we had everybody was admitted. So we can see there are many patients. Out of almost 240 patients, we had 208 had mild cases just admitted at that time because everybody was admitted. Now mild cases are managed at home or home isolation. Moderate to severe were around 24, newborns were 23. 3 deaths occurred because of COVID illness. MISC was not present at that time because it was not entity to be known at that time. But in second wave onwards, MISC has come into the picture, and we have 12 MISC patient children up to 18 years of age and 3 deaths related to MISC. So that is why preparation is of this possible wave is mandatory. So what is basis for today's webinar is a basis will be pediatric COVID-19 field training workshop. This training workshop has been taken to various doctors and nurses. It is ongoing process, district wise or even taluka wise all over Maharashtra, because it is a government of Maharashtra task force which has explained this tool or workshop tool detailed by eminent faculty, and Dr. Jitendra Gawane is one of the member of that task force. He was actively involved in the framing this particular workshop module. Now this is today's, this workshop module will be today. Tomorrow it will be more of hands-on or practical experience shared by MGM faculty who are actively working in the field of COVID since last more than 1 year, 3 to 4 months. So today is basic module we will be teaching by eminent people, and then tomorrow is the hands-on workshop, and there will be a possible chances those who are interested will be arranging the modules, these practical modules in the skills lab also. So with this introduction, I stand and thank everybody for listening and hand over mic to the actual starting of government approved model to Dr. Jitendra Gawande. Thank you.
Now I would like to invite Dr. Jitendra Gawande, Professor in charge of PICU, MGA Medical College. He is also the president of IAP Navi Mumbai and member of Government of Maharashtra Pediatric Task Force. Sir, over to you, sir.
Thank you, MGM Nursing family, for giving me opportunity to share the work Maharashtra Pediatric Task Force has done for possible third wave, which is considered as a pediatric wave, which is a kind of misnomer thing. Only percentage of people affected out of 100, many will be pediatric. That is the only real meaning of the term pediatric wave. It will not be all 100 cases will be pediatric. Out of 100, first wave we saw less than 5% cases were pediatric. In second, up to 10% were pediatric cases, and we are expecting in third wave up to 20% cases will be pediatric cases. So actual 80% load will be the adult load only, but for handling this 20% of the cases which will be pediatric, are our infrastructure and machineries are please mute yourself, whoever is I'm Anna, you are please mute your mic. Yeah, so government has given us a task to be prepared, not just for the COVID kind of calamity which comes once in a while, but to prepare our infrastructure so that every year the various epidemiological or various emerging and re-emerging infections might come, which might affect the pediatric population, and our infrastructure should be good enough in terms of manpower, in terms of machinery, in terms of monitoring, so that we can handle any of such wave, whether it is a COVID related or whether it is a H1N1 wave, which is postulated to come next year, or avian flu or whatnot. So for that, it is not just related to COVID. So with this preamble, I'll start my share screen. So government thinks that now third wave will be totally handled by pediatrician and pediatric nurses and people who are handling pediatric cases, but it's not actually like that. So this is just a slide I showed. I'll start my presentation now. Yeah. Is it visible now? Yeah. So Maharashtra government was the first to sense that something might come as a third wave, and they started preparation really very fast. And in the April month itself, Chief Minister Shri Uddhav Thackeray formed a committee, and he took few meetings. He gathered the data from world over, and he said whether our infrastructure is ready to handle, if at all 20% caseload will be of pediatric, if at all any COVID pediatric wave is going to come. So we realized that not just Maharashtra, but none of the state in India is readily equipped to handle such massive caseload which can come suddenly, and which can paralyze the entire health infrastructure. Because more emotions are attached with the pediatric cases, it will be a disaster if we are not ready. So as early as April, where actual second wave was at peak, that time we started the work, and this is the all members who are the part of the committee, and I'm fortunate to work with the stalwarts of across Maharashtra, these pediatric stalwarts. So I'm thankful to the government for including MGM in this task force. So SARS-CoV in children can present in two ways. Either it will be acute COVID illness, or it will be something called as multi-system inflammatory syndrome of children. In acute COVID illness, majority of the cases, that is to the tunes of 90%, will have mild course with quick and complete recovery. So within a week, child will be all right, and he will have just minor symptoms, which sometimes may not be there also. He may not realize also. So most of the case load will be of those cases which are mild, but can be followed by complications like COVID, pneumonia, like in adults, and incidence is very much less. I'll come to the real incidence later. The second variety they can come is a multisystem inflammatory syndrome of children, which is a MISC or MISN, where it is coming in the neonate. So this is a actually post-COVID phenomena, which is a non-infectious in nature, which can be handled in a normal green zone PICUs and wards. So it is not really a COVID isolation, but case load will be more. This can occur few weeks to few months after the acute COVID illness. To be precise, 2 weeks after the COVID illness, up to 3 months of post-COVID time frame, these children can develop this multi-system inflammatory syndrome. Now, out of 800 to 1,000 COVID positive children who have got COVID, whether they were diagnosed or not diagnosed doesn't matter, but if they have got COVID in last 3 months, there is a possibility that out of those 800, one child will develop multi-system inflammatory syndrome of children. This can be seen sometimes in neonate born to COVID positive mothers as well, because mother is already had COVID infection in the pregnancy, and 2-3 months have passed, and now the child is manifesting at birth with the symptoms and signs of multisystem inflammatory syndrome, which is labeled as MISCN. So pediatric COVID spectrum will be asymptomatic children or mild cases, which will be the tune of 90 to 95%. Moderate cases will be 5% or less than 5%, and severe will be very, very less, which include MISC or MISN plus pneumonia, all together constituting maximum of 1 to 2% of the entire case load of the pediatrics. So severe cases requires high-level treatment in COVID care PICU or HDU. The moderate one can be managed in a special dedicated area, which is called as pediatric COVID care hospital. And the mild ones and the asymptomatic ones are always given home care with daily follow-up. One additional point here is a daily follow-up by teleconsultation or some form of communication with the treating either nursing staff or the doctor or the intern, whoever has advised them home care. He needs to be with the touch of the treating person or fever clinic person. Now, what is this fever clinic? What is the concept of fever clinic? It is the first point of contact for medical aid to all children with fever as the main symptom and probably the only symptoms. We know that this is a monsoon season, and third wave unfortunately is coinciding with the monsoon period, which already every year gets its own burden of monsoon illnesses, right from malaria, typhoid, dengue, leptospirosis, hepatitis. On top of that, we may handle this time COVID infections. We are hoping that this should not overlap with the monsoon illnesses, so that it is easy for the infrastructure industry to handle the caseload. So fever will be the only symptom sometimes in these children. So role of the fever clinic doctor will be, we have to think whether it is likely to be COVID or non-COVID illness. Is testing required? Now, this question looks very simple, but answer is very complicated. No one can be sure of any diagnosis within first 2 days of fever, whether it is a COVID or whether it is a malaria or whether it is a dengue. So all of them are coming with the fever. So only few diseases which are coming with the telltale signs like fever, high-grade fever with chills and spleen palpable and pallor. We know that the child is probably having malaria. So that exclusivity can be applied here, but mind it, take it from me, none of the diagnosis is possible on day 1 or day 2 of the fever. So we have to consider all these cases as probable COVID cases unless proved otherwise. If they are if COVID is likely or proven, then the most important thing is doing triaging. Now we have to triage the patient whenever he's coming to OPD into whether it is a mild case, which can be managed at home, or whether it is a moderate case with some comorbidities, with or without comorbidities. We need to admit them to the pediatric critical COVID care hospital. It will be a COVID ward kind of scenario. And the severe one, which requires direct PICU or COVID care PICU hospitalization. In mild cases, where which one we are sending home with the instructions to the parent is instruct parent on home management and red flag sign. Remember the onus of giving home management. If you are writing home care management or quarantine at home for 18 days or 17 days, whatever is government protocol, that time onus of monitoring him lies with the parents as well as you as the advising doctor. So we need to develop some form of communication with the patient. So at the end of the day, at fever clinics, how many we ask to do home monitoring, then every day some intern or one of us will sit at the end of the day and just ask ki last 7 days ke patients ko ki are you okay, or just send a WhatsApp message. Some form of communication is required to know whether they are all right or whether they are developing some red flag sign, because once red flag sign develops, there will be no time for the children to crash down. So we'll take one case. This child is coming with the fever since 2 days, 13-month-old child. So our first question will be, could it be a COVID? Symptoms and signs of COVID are non-specific and mimic any viral illness. So we need to ask for onset, trend, interfebrile period, whether when fever is not there, whether child is playful or no, whether there are any associated symptoms are there or no, like headache, myalgia, fatigue, tiredness, cough, cold, coryza, rapid breathing, diarrhea, vomiting. So these all are the exhaustive list of non-specific signs and symptoms. So probably we are calling this as a COVID symptomatology only, because this is very commonly seen in COVID infection, but they are seen in other forms of infection as well. So are we sure that this is a COVID only or not COVID only? So we have to ask whether there is a next question. We have to, these points we have to write on a paper, whether there is a history of close or household contact with the COVID. So they might come out with the answer that yes, the uncle is right now at home and he has got COVID. Then we have to ask whether there was a history in past 2-3 months or history of COVID in last 2-3 months in the parents and all. This is for in view of MISC. Then we have to ask history of comorbidity. It's not, there is a misconception in many people, many adult physicians and adult patients also, that children may not have comorbidity. But mind you, there is a huge list of comorbidity which can aggravate the symptomatology of COVID. So we need to ask whether the child is having any of such comorbidity. Then we have to go in a little bit of socio-economical history of family and housing details. How many rooms are there, whether elder people are staying at the home, how is the bathroom, whether single bathroom is shared by many people. All those epidemiological things, we need to have details in our OPD paper. So So what about COVID test? We took this case and then we decided this is a probable COVID. So what about COVID test? Testing is recommended ideally for all these probable suspected cases of COVID. Whoever is coming with the history of fever of 1 day, 2 day, 3 day, we need to test them immediately, because the maximum yield of the test is on day 1 and day 2 of the fever, and the yield goes down when the child is having a prolonged fever for 3-4 days, 5 days. The probability of testing truly positive COVID cases goes down. So testing is recommended ideally in all types of such cases. However, if resources are scarce, testing may be deferred for children with mild symptom and no comorbidity. But here there is an asterisk that if no comorbidity is there, if an educated person is there to monitor this child at home, and there is a known positive contact and we are still advising them COVID home quarantine, but we could not do tests because of that time the testing facility was not available at that point of time. So then we are labeling them as probable COVID. Even if we are not testing, we are labeling them as a probable COVID. So which test we need to do and in OPD basis? So rapid antigen test is very good, which gives results within 30 minutes. And if symptoms are and known positive contact is there, definitely immediately we should do rat test. And as we know, rat test is having sensitivity of 50% only. So if rat test is negative, it will not rule out the COVID. So we, in those cases where probable COVID is a diagnosis, we have to do COVID RT-PCR. So most important thing remains is what is your turnaround time of RT-PCR test in your institute. So we need to what we say accelerate the time period required for testing and getting result, and that will reduce the spread of the disease in the community. So this case, that 13-month-old child had mild fever since yesterday. He didn't have any cough or cold or vomiting. Physical examination was essentially normal. Father was under home isolation for 5 days because he was diagnosed as COVID, and mother was asymptomatic, not tested, but she is breastfeeding this child. Other members in the family are older brother, father, 65-year-old grandmother, and they are staying in 2-room apartment with a common toilet. So our diagnosis is it is a probable COVID or confirmed COVID if our RT test is coming positive. But we are categorizing this case as a mild COVID. Mild because when we are going to call it as a mild case, when there are no signs of fast breathing, the child is not lethargy, the child is not having convulsion, the child is playful and active when he is coming to our OPD, and there are no signs and symptoms of dehydration. So if these 3 things are not there and child is coming with only fever, then only we are calling it as a mild COVID-19, probable or confirmed depending on the test, and depending on this result, we are calling it as a we are deciding to advise the home quarantine today. Now, what is meant by fast breathing? We know IMNCI, all sisters and doctors and junior doctors and other MBBS students are always bombarded with this cutoffs every time they come in pediatric OPD, pediatric posting. So any child who is less than 2 months of age, his breathing rate should be less than 60. Anything more than 60 is considered as a fast breathing. If the child is 2 months to 1 year, then this cutoff becomes 50 per minute. If the child is 1 year to 5 years, the cutoff becomes 40. So anyone who is having respiratory rate of more than 40, it becomes a respiratory distress or fast breathing. And beyond 5 years of age, the cutoff is 30 per minute. So anyone who is breathing at the rate of 32 and he is more than 6 years old, then definitely he is having fast breathing. So this should be counted for 1 entire minute, and we should teach the father or mother or caregiver how to take this respiratory rate in 1 minute. If parents are taught this, the monitoring at home becomes extremely easy. What next? So we have to ask at that point of time whether the child is having any comorbidity. We were just now discussing the comorbidities. So if the child is having any cardiovascular disease, hypertension, congestive cardiac failure, the congenital heart diseases or acquired heart diseases like rheumatic fever, if the child is diabetic, newly diagnosed or old diabetic patient, the child is immunocompromised child, he's taking some immunocompromised drug like steroids for some other reason, whether the child is having chronic lung disease, chronic kidney disease, chronic liver disease, whether the child is having any neurological disease, obesity, again malnutrition and obesity, these both are the comorbidities for children who are having a fever, because they can have a severe illness. So we need to monitor them very carefully. Anyone who is having this comorbidity, we need to monitor them very meticulously. So if the comorbidity is there, and if there is no ready access to the healthcare, these children cannot reach someone who is staying in, say, Dodhani village. This is very difficult for Dodhani child to come to MGM in the odd hours, like after 5 o'clock or something, and he is having comorbidity with fever. So we need to admit such children to PCCH directly without any thinking twice, and we should not advise them home quarantine. If there is a facility of referring or coming back to our hospital readily available, then only we can take a chance that we can still send the child with a warning signs that these needs to be monitored at home. Then we can continue as per the mild disease at home with a asterisk that immediately we need to call back. And in our OPD paper and our register also, we should make a star of these children who are having comorbidities, so that whenever we get time, we should call back them and ask whether your child is okay now, usko ye red flag signs to nahi aaye na. So it's very important to rule out any comorbidity in the child. So this child has been advised home supervised home care. So he will be at home for 14 days quarantine. Remember, one mistake always is done is that whenever the child at home gets a COVID or labeled as COVID, all parents send them to grandparents' house or send the child to some other room. So don't do that. Don't send the children to elderly people, because the elderly people getting infection from these children who are having mild disease is very high, and elderly people will develop a moderate to severe disease. So please separate the elderly from the house rather than separating this child from other family members. So other family members need to wear masks, and grandparents should be strictly separated in a separate room, and this child should be continued with the mother. Full normal diet, extra fluid intake, continue breastfeeding, warm saline gargles in older children whenever possible. Don't give the steaming and all. There are a lot of cases of burns with the steam. Please discourage the steaming at home. Just warm saline gargle or warm liquids to drink, like hot tea or soup is good enough. Then symptomatic treatment can be given for fever with paracetamol and the sponging. Remember, there is no need of antibiotic and no need of any investigation to be done in this child, except for that rat test which we have done. Home monitoring by the parent or the healthcare worker in that village is very, very important. Now, every village has been assigned with one healthcare worker in the form of ASHA worker or Anganwadi worker, or the teacher staying in that area, whosoever, or the parent himself who is educated good enough. Now, this scenario may not be applicable to urban area like us, but this is very important for rural population. So someone needs to teach the parents monitoring, or they themselves should do the monitoring part. And what needs to be monitored? It's very easy: temperature, pulse, saturations, urine output, and rapid breathing. We have to monitor this on a specific chart. Report daily this to the fever clinic by phone, message, WhatsApp, either to Anganwadi worker or to the fever clinic staff, or proactively fever clinic staff should call up and ask you whether your child is okay or not, till the period of defervescence, that he is febrile and well. That usually is 3 to 4 days only. More than 3 days fever is very, very less likely, and if it is beyond 3 days, it is definitely not a mild disease. So we need to monitor for 3 days. So it is good enough and good gesture to call back and send message and ask whether your child is doing fine or no. So this is a simple chart which we need to give to the patient every time we are sending the patient back with the home quarantine label. Now it is our duty to explain them ourselves how to take readings of this very simple chart. Thrice a day we are doing the monitoring, 8 a.m., 2 p.m. and 8 p.m. and whenever required, temperature, pulse rate, respiratory rate, SpO2 monitor. Now pulse oximeter, we should encourage all parents to have, all houses to have one pulse oximeter common for it. Sometimes smaller child, it is difficult, but at least uniformly we can still manage with the pulse oximeter. Then we have to monitor the urine output, and we have to see whether other symptoms are coming in this child. Now this child, if required, this chart, if required, we can print in a vernacular language and keep in the fever clinic. And with your fever OPD ka paper, we should attach this and give to the parents. Behind this, we are planning to have some pictorial pictures of the red flag signs which needs to be seen by the parents, and isme se kuch hua to immediately they can call up the fever clinic and tell that my child is having one of these red flag signs. So here we are going to write the cutoffs of the respiratory rate. We are going to write temperature more than 102 as a something which is important or red flag. Sometimes we need to chart the urine output as well. If child has not passed urine in last 6 hours, that is also one of the red flag sign. And the temperature, SpO2 monitoring. Whoever is having pulse oximeter reading 94 or less will be considered as a red flag sign for that child. So this is to be filled by parent or caregiver at home and informed to fever clinic staff daily at allotted time, which we can work out, can read out on the phone or send the WhatsApp photograph. Something, some form of communication is definitely required. Then we will continue with this. As we said, no antibiotics and no investigations, and daily reporting to the fever clinic doctor. Watch for red flag sign. We are always saying red flag, red flag. What are these red flags? We have to spend an extra minute in the fever OPD itself to explain to the parents that these are the red flag sign, and if any one of them is coming, we need to quickly call up the fever clinic again, or go at appropriate place and get your child further assessment. Remember, this red flag is anyone. So persistent fever more than 3 days, unlikely it is a mild COVID, or it can be some other non-COVID illness coming up. So we need to be very alert when fever goes beyond 3 days of illness, 3 days of period. Then decrease urine output. We decided that in 6 hours at least child should pass urine once. If it is less than that, then it is a red flag sign. The child is drowsy, lethargy. There is a rapid breathing above that cutoff limits. There is a pulse oximeter showing saturations of less than 94. There are rashes coming on the bodies. There are red eyes, red lips, red tongue. This occurs in a Kawasaki variant of the MISC. The child is extremely lethargic and having altered sensorium or sometimes convulsions also. So these we are labeling as moderate disease. And when we are labeling this as a moderate disease, we should tell the parents to call up the fever OPD or call up the hospital or your treating doctor and get it doubly checked by the treating doctor, at least on phone, that really it is a red flag sign. Sometimes saturation probe, if we are not attaching it properly, sometimes it can give wrong reading. So let the doctor on phone confirm that repeated reading of 1 or 2 times is still showing persistently less than SpO2 of less than 94, then definitely it is now moving in the category of moderate disease. So for moderate disease, I request Dr. Revati to speak on moderate disease. I think questions are taken later or at this point of time, depending on the moderator.
Thank you so much, Dr. Jitendra, for giving a valuable information about the various categories of COVID-19 and the various diagnostic criteria to rule out the same. Sir has also given different case scenarios, which was very realistic. Thank you once again. Thank you so much, sir. So now we'll move towards the next session by Dr. Revati N. She is currently working as an associate professor, MGM Medical College and Research Institute, Kamote, Navi Mumbai. She is specialized in pediatric neurology and she has more than 16 years of experience in pediatrics, and she has various peer-reviewed publications. So, ma'am, please, over to you, ma'am, for the next session.
Thank you, MGM Nursing College. And thank you, Dr. Jitendra, for handing over this patient to me. So as we have seen, this child was, am I audible?
Yes, yes.
Revati, please make it full screen.
Okay, so till now we were managing this child at home. Okay, the first 3 days we were meticulously managing the child at home. Child was having mild fever and rest of the parameters were fine. Now, as we are monitoring, we find that even on day 4 of illness, the child is continuing to have fever. So about 101 fever is there in the child. And not just that, not just fever, we also notice that the child is dull, little lethargic and not eating that very well. And the urine output is less. Although there is no breathing difficulty, we notice that the child is having a little bit of tachycardia. So as we saw the signs of red flag signs, so these all point towards the fact that something is not all fine in this particular child. So we have so many features like dullness, lethargy, persistent fever, not eating well, decreased urine output. So what is the thing we have to do in such a case? So we have to uh, just excuse me. Yeah. So once all these symptoms appear, what we have to do is we have to the parent or the ASHA worker or the person who is in charge of this child has to immediately inform the fever clinic. So once the fever clinic is informed, what does the doctor do? He has to confirm if all these concerns are true. Actually, the doctor can, because nowadays we have online system or teleconsultation is there. The doctor can see the child through a video call, or if possible, they can personally see the child and confirm if all these factors are really true. If the child is lethargic, not eating and all those things, and then confirm that this is a moderate disease. Now that the moderate disease is confirmed after assessment, what are we supposed to do? We have to see the status of the rapid antigen test and the RT-PCR or the RT-PCR report. So as we told, whenever possible in all children with fever, we need to do a rapid antigen test or RT-PCR report. If the test result is positive, then we have to admit the child in the pediatric COVID care hospital. Okay. If suppose the child, so when you are planning to admit the child in the pediatric COVID care hospital, you have to make sure, obviously, small children will require some bystander. So it should be a family member, preferably somebody who is young, who is vaccinated, or who has recently recovered from COVID. So these are the people who can be kept with the child. If there is no option, the mother can be allowed to stay with the child. Or if it's a smaller child who is on breastfeeding, still you have to keep the mother with the child. Explain to them the risk of being in the hospital, and then you will have to counsel them, and you have to keep the mother with the child in such a condition. The next, in case the test report is negative, or if the tests are not done, then what do? We have to keep this child in a separate area. So in our hospital in MGM, we have what is known as the suspect ward. So we keep the child in the suspect ward, or if it is in a rural hospital, then we can keep the child in a separate area until the reports are available. So we have to do RAT, and if RAT is negative, then we have to treat this child as a non-COVID. The cause of other causes of fever should be ascertained. As Dr. Jitendra told, this is a monsoon season. There may be many other causes for fever. So we'll have to ascertain the cause for fever and then treat the child accordingly. But if RT-PCR report comes positive, then we have to admit the child in the pediatric COVID care hospital and with the bystander. Now, till now we have noticed that we have just done the rapid antigen test or RT-PCR. We had not done any other investigation. Now that the child has come to the COVID care hospital, we need to do certain baseline investigation, either to confirm the diagnosis or to see if the child is having any other comorbid factor. So first and foremost, we have to do the complete blood count. A complete blood count will let us know whether it is a viral infection, because although COVID test is positive, we still are open to the fact that the child may be suffering from something other than other infection also. So a complete blood count will let us know if the child is having COVID, or is there a possibility of other infection also. So we look at the total leukocyte count and then see whether it is a neutrophilia, which may suggest the possibility of a bacterial infection, or we see whether there is increase in the lymphocyte count, or if the total count is low, then that will also point towards a possibility of a viral infection, probably a COVID only, and we'll have to look at the platelet count. So a baseline complete blood count is very important. The next important investigation we do is the C-reactive protein. So C-reactive protein is important because the severity of disease, it is a marker of infection as well as inflammation. So
Excuse me, ma'am.
yes,
Are you changing the slides?
yeah,
But we could not see, ma'am.
okay, on my screen it has changed.
Yeah, we can see only the first slide.
Okay. So sorry for the disturbance. So actually, I was talking about the investigations. So it is the CBC. I explained to you why a CBC is required. Then we have the CRP. So CRP is a marker of infection as well as inflammation. So increase in the CRP should caution us towards the possibility of an infection, or later on as we see, this may be a indicator of a MISC also. So a baseline CRP is very important. The next important investigation is SGPT, so a liver function test, and also serum creatinine. So serum SGPT, serum creatinine, serum electrolytes, these are all important because we may be starting this child later on certain medication for which these values need to be normal. Any abnormality will be a contraindication to starting certain drugs. So a baseline value need to be there: SGPT, serum creatinine, and serum electrolytes. Serum albumin, again, it is an indicator of the liver function. Plus, it has got a prognosticating value in case of severe illness. So we need to have a baseline serum albumin value also. And then we have chest X-ray. So again, I would like to tell you that in children in whom we are suspecting a moderate illness, like child is having a rapid breathing, or child is having persistent fever, or you notice that child is having other signs of pneumonia, we need to go for a chest X-ray to see whether there are any features of lung infiltration. And again, here I would like to stress upon the fact that all that is needed is a chest X-ray. So many of us, or many parents also, may force us to go for a HRCT or higher investigations. So we have to tell them that those things are not going to alter the treatment in any way. So what we require is chest X-ray and not a HRCT, at least at this point of time. Okay, then we have to do additional investigations if the child is having any other comorbidities. The list of comorbidities were already mentioned. So we may have to monitor the blood glucose. We may have to monitor the liver functions. We may have to monitor the renal functions, depending on whether the child is having a underlying renal disease or a cardiac disease or a liver disease. So we need to take care of the comorbidities also. As you all know, comorbidities may increase the severity of the COVID infection. So it is very important to monitor the child for comorbidities, and we have to keep the other comorbid conditions also in control while we are treating the COVID infection. So investigation and monitoring happens side by side. So will be doing all these investigations, and side by side we'll be monitoring this child. So what are the monitoring parameters that we'll be monitoring? So even at home, we had told the parents that they should be doing monitoring the temperature, pulse, respiration, etc. So in the hospital also, we should continue monitoring the child for temperature, pressure, pulse, and respiratory rate fortnightly. Another important thing is blood pressure. See, in pediatrics, we are going to deal with children of different ages. So you will have a child who is weighing just about 3 kgs, a newborn baby, and you will have a person who is about 18 years of age. So it is important for us to keep sphygmomanometers with appropriate size cuff, so that we are not missing out on these points. So many a times practical problem is that when you ask the residents like what happened to the blood pressure, then they end up telling I didn't get the right size cuff or something. So we need to make sure that these things are available and monitor the blood pressure at least 8 hourly, because an increase in the pulse rate and a decrease in the blood pressure is a pointer towards the onset of shock in this child. So this child directly goes on to the severe, goes to the severe category. So we have to monitor the child carefully for any fall in the blood pressure. And the third very important thing is monitoring the SpO2. So if the saturation is more than 94%, you can monitor it too early. We can teach the bystanders also, and the resident or the intern or the sister there should be checking out the SpO2 every too early. But if the saturation is between 90 to 94%, that is less than 94%, then you have to monitor the SpO2 continuously. Okay, because this child is a borderline child, so you need to monitor the saturation continuously. Another important parameter that you will be monitoring is the AVPU. So what do you understand by AVPU? It is the alertness of the child. Okay, so if whether A stands for alertness, so the child is alert, active, and child is recognizing parents, playful. So we are not much worried about this child. So this child is alert. And V is response to only verbal stimulus. So the child is drowsy most of the time, but whenever the mother calls out or the doctor calls out, the child at least makes a verbal response, or the child responds to it. So any verbal command, the child responds, that is V. What is P? So P stands for response only to painful stimulus. So the child responds only to the painful stimulus.
Initially, you are supported also. Kindly continue your support.
There is some disturbance.
There is no chances of skin irritation. Vocal packing, so maintain the thermostability.
Okay, so P stands for, P is when the child responds only to deep painful stimulus, and U is unresponsive child. So the consciousness of the child has to be monitored using these 4 parameters, whether the child is alert all the time, or the child wakes up and only to verbal command, or the child wakes up only to painful stimulus, or the child is unconscious. So as we will see later, if the child is in P and U category, then the child is very sick. Okay, the next we have to look into the intake output chart. So we have to strictly monitor the intake. Generally, when a child is sick, their tendency to eat will be little less. So we have to take a little extra effort to feed the child properly. So how do we make sure that the child is taking properly? So we need to have objective evidence. So we have to monitor the intake and monitor the output also in these children very meticulously. And then if the child is having, as I told you, if the child may be a diabetic, so we need to monitor the diabetic status of the child by doing regular blood sugars, or the child may be having other comorbidities. So depending on the underlying comorbidities, you may have to monitor additional parameters also. So basic, we will be monitoring the temperature, pulse and respiration. BP should be done 8 hourly. Saturation should be monitored too early if the child is more than, if having a saturation of more than 94%, and continuously if the child is having a saturation less than 94%. Assess the alertness of the child by doing AVPU regularly, at least 8 hourly. Intake output chart should be maintained, and additional monitoring has to be done in children who have comorbidities. So what do we, where do we go next? Yeah. So, I think I skipped one slide. One second. So after investigations, okay. So now what all will we be doing? So we have investigated the child. We are monitoring the child. So what treatment are we going to offer this child? Again, the main aspect of the treatment is supportive. So we have to give a good supportive care to this child. Keep the child well hydrated. Give more frequent breastfeeds if the child is still on breastfeeding, or you can ask the child to consume more fluid. A older child, you can ask him to consume more fluid. If the child is unable to do so, then we may have to start the child on IV fluids. But maintaining hydration is very important. Maintain the nutrition in this child. So child should receive all appropriate nutrition as per the age requirement. And if the child is having fever, in this case, we saw that the child is continuing to have fever. So we can continue to give paracetamol paracetamol at 10 to 15 milligram per kg per dose, 4 to 6 hourly, as frequently as 4 to 6 hourly, we can give paracetamol. If there are other symptoms like nasal block, then we can give nasal saline. Again, it is saline nasal drops only. You can give it any number of times depending upon the requirement of the child. And if there are any other symptoms which the child is having, then we can treat according. We just give a symptomatic treatment, and multivitamin supplements can be given. So if in case the child is requiring nebulization, so child is having mild respiratory distress or is having bronchi, then we may, and if there is a requirement to give bronchodilator to this particular child, it is always preferable to use a meter dose inhaler, because the meter dose inhaler, as you all know, in pediatrics, we use it with a spacer. So we use it with the spacer so that it becomes convenient for the child to use. And why we prefer MDI over nebulization is nebulization produces lot of aerosol. So you are here giving nebulization to a child who is positive, and any aerosol produced can result in spread of infection. So you don't want that to happen. And so we don't use nebulizer. We advise MDI with spacer in children who are in need of bronchodilators. And what is the role of antimicrobials? So if in the investigations or while examining, if you are strongly suspecting that this child is having a super added bacterial infection, then it becomes important to give antimicrobials. So we can start off with ceftriaxone at 75 to 100 milligram per kg per day. So again, in the investigation, we are looking for evidence of bacterial investigation. So we are doing CBC, we are doing chest X-ray. If we are fully convinced that this child is having infection, then bacterial infection, then we will give ceftriaxone. There is no role for any other medication in children. Now we are going, and if the child is having comorbidities like diabetes or liver disease, renal disease, whatever treatment the child is on for these diseases, we'll have to continue the treatment even in the COVID care hospital. Now, what else are we going to do? So here, as I told you, if the saturation is more than 94, then we are going to monitor the saturation every 2 hours. But if the saturation, the child is between 90 and 94, so it becomes imperative to give these children oxygen. So we have to give oxygen. Again, there are several methods of giving oxygen. Depending upon the comfort of the child, depending upon the availability and the age of the child, we may choose any of the oxygen delivery device like nasal prong, mask, or oxygen hood, non-breathing mask. So any of the thing which is suitable for the child should be used. And then awake proning. So awake proning is very important. So a little older child, you can explain to them the positive effect of awake proning, and you can ask them to be lying down in the prone position. A smaller children may be little difficult to convince, but I think in the presence of parents, they also will be quite cooperative. So what is the use of awake proning? It improves the lung capacity. So there are more alveoli recruited into the breathing process. So it becomes, there are more alveoli taking part in the respiratory process. So it helps in improving the saturation. So what else can we administer to this child who is having a low saturation? Is IV dexamethasone. So IV dexamethasone is indicated in children in whom you are suspecting that the disease is progressing. So saturation is falling and there is evidence of progress in the disease. So we administer dexamethasone 0.15 milligram per kg per dose once daily. So maximum is 6 milligrams. It's not like if you have a child who is 70 kgs and still you will give 0.75, which means it comes to about 9 milligrams or nothing else. So maximum dose is 6 milligrams, which has to be given for a period of 5 to 14 days. IV remdesivir, this is a drug which has to be used with a lot of caution. And the recent recommendation is that the safety is not established in children less than 18 years. However, if the treating doctor feels that there is an absolute requirement to start remdesivir, like in a very progressive disease with due consent, the drug can be started. So Dr. Suhas will be talking more about the medication, but as of now, at least in moderate disease, there is not much role for IV remdesivir. Okay, and moreover, as I told you earlier, we were doing SGPT, we were doing serum creatinine and all. So that is to again see whether you can administer certain drugs. So here we see that if at all you happen to give remdesivir, then it is contraindicated if the liver functions are altered or if the renal functions are altered. So in children with liver disease, renal disease, you don't give remdesivir. Again, the safety profile of remdesivir is not established in children less than 18 years. So, you have to be very cautious, and the treating doctor has to take a very careful decision regarding remdesivir. So now, okay, we have kept the child in the hospital. We have been monitoring the child. So two things can happen. The child can improve or the child can deteriorate. So let us see the positive thing first. So that this is, you have a child who is improving. So now we have to plan discharge of this child. So when will we discharge this child? When the child has no fever for more than 3 days. So when the child comes to our hospital, that is a pediatric COVID care center, only when the child has fever of 3 days at least. And after coming to the hospital also, it is possible that the child may not have fever at all, or the child may have fever for another couple of days, and after that child may be stable. So if there is fever, no fever for more than 3 days, or 10 days from the onset of symptoms, whichever is later. It's not that the child came to hospital on the 4th day of fever and 2 days later the child is afebrile and then you discharge. No. If the child, even if the child is afebrile, if you have to see how many days have passed since the onset of symptom. So you have to keep the child in the hospital for at least 10 days from the onset of symptoms. And what do you do? So we are dealing with pediatrics. So most of the children less than 5 years are having vaccinations and scheduled vaccinations. So the parents would naturally ask, like, I have my appointment after next week or so, can I give the vaccination? So ask them to defer vaccination by at least 4 weeks after the onset of illness. So defer vaccination, but at the same time, you have to ensure that the child is completing the vaccination. So many a times the date goes by and then afterwards you forget about that vaccine altogether. No. So you tell them, give it after 4 weeks, and tell them the importance of completing the routine vaccines. So discharge the child with, give them good advice about the vaccination also. Now, the other aspect is the child is not improving. So when will you decide to transfer the child to a higher level of care, that is the HDU or PICU? So as we see, the saturation, despite being on oxygen on NRF, the saturation is not improving, or the saturation is less than 90%. It is an indicator of severe disease, and you have to shift the child to a HDU or a PICU. If the child is having severe pneumonia, increased respiratory effort with grunting, retraction, cyanosis, so all these are suggestive of severe pneumonia. So if the child is having evidence of shock, as I told you, you have to monitor the BP regularly, the urine output regularly, the pulse rate regularly. So any increase in the pulse rate, decrease in the blood pressure, decrease in the urine output, all these may mark towards the onset of shock. So if the child is having any of these symptoms, then again, it is an indication to shift the patient to HDU or a PICU. And next, altered sensorium. So as I told you, alertness, response to verbal command, response to pain, and unresponsiveness. So these are the 4 parameters that we are monitoring. We have been monitoring in this child. So if you notice that the child is altered, that is, the child is responding only to deep painful stimulus, or the child is unresponsive. So in both these conditions, you will have to immediately think of shifting the child to HDU. And if the child is having refractory convulsions, so the child starts convulsing, again an indication to shift the child to PICU. If the child develops features of MASC, so was described earlier, so if the child starts developing rashes, redness of eyes, and if the child is having abdominal pain, so the symptoms will be detailed to you later. So if there are features of MASC, again shift the child to HDU or PICU, or if you see visible clinical bleeding. So the basic point is, if the child is not maintaining saturation, signs of pneumonia, the child is in shock or any alteration in sensorium, this child needs to be shifted to PICU. While we decide to shift to PICU, there are certain precautions that we have to take. We cannot just tell the parents, okay, now your child is now cannot be managed in the pediatric COVID care center, so you will have to go to a PICU or HDU. So the parents are already in distress. So it is our duty to tell them exactly where to go, and we have to first call up that particular COVID PICU or HDU, confirm the availability of bed, and you will have to probably reserve the bed for this particular child. Tell them that the child will be reaching your hospital in this much time, and then you have to plan to shift the child to PICU or HDU. And while you plan, again, it is the responsibility of the treating doctor and the treating team to ensure that this child is shifted to the hospital in a good state, and the child should be safely shifted. So there should be no problem in shifting the child from the pediatric COVID care hospital to the HDU or the ICU. So what are all the things that we have to look into? First, check the airway. So we are dealing with a child who is oxygen dependent now. That is, the saturation is less than 90%. Child may be requiring oxygen by NRM, or the child many a times may be intubated. So check the position of the endotracheal tube and make sure that the tapes are fixed well, it is dry. Suction the child well, because otherwise on the way there is a chance that the tube may get blocked. So suction well before the child is kept in an ambulance. And then breathing, optimize oxygen delivery. So the person who is accompanying the child also should be well versed in giving a good bagging. So the chest rise should be fine while you are bagging. So this ensures again that the tube is in right position and the oxygen is reaching the child. Ensure that the BP and the perfusion is good. If suppose the BP is borderline and you are not sure if the child will sustain the blood pressure until they reach the HDU or ICU, give a bolus before transfer. And drugs, again, give bolus of sedative so that the child is not aggressive or irritable while transferring. So this may end up in pulling out the tubes or any accident on the way. So give a bolus of sedatives before loading. And more important, make sure that a right amount of all the emergency drugs, adrenaline, atropine, inotrops, anticonvulsants are available in the tray, which is going to go with the child. Okay. And stop feeds. Again, if the child throws a convulsion or if there is a need for re-intubation, which should not be, but if at all it is there, if the stomach is full, this may result in aspiration. So we have to stop feeds and decompress the nasogastric tube before leaving so that such aspiration episodes can be avoided. And IV lines are very important. At least 2 IV lines should be there. One in case you need to give an emergency drug, you need to have a line, and of course IV fluid should be continuing. Child may be on inotropes on the way, so you have to maintain a patent and nice IV line, at least 2 before the child leaves the hospital. And more important and very important is to carry all the case papers and investigations. Sometimes you go to the hospital and then you see that, okay, the COVID report is not available, or some patient related investigation documents are not available. So again, that should be avoided. So ensure that all the papers and everything is taken correctly in a file, and then it is sent along with the child. And if you can have a printout of the emergency drugs according to the baby's body weight, it would be very helpful for the doctor who is or the team which is accompanying the child to the hospital, because they can readily administer medication in case there is any emergency need. So maintain airway, breathing, circulation, ensure that all the drugs are available with the emergency drugs are available with the transferring team, and stock feeds and fluids and has to be continued, and patent IV line is important, and all the documents need to be carried. So now this is the individual role. So a transport team, you cannot just call an ambulance and send the child with the parents. So you have to go there as a team. So a doctor should be there, a nurse and a paramedic should be there. These are the ideal circumstances where they all should be there. So this is when, you know, like when a child is being transferred from an outside hospital to a COVID care center. We may have a situation like in MGM where the pediatric COVID care may be happening on the first floor or the second floor, and the HDU or ICU is on the ground floor. So inside hospital transfer also should happen in a very smooth way. The resident should call up the concerned ICU or the HDU in charge and reserve the bed, ensure that the bed is ready, and then shift the patient down. So whether the distance for transferring is short or long, the whatever equipments which are needed, all the whatever I mentioned in the previous slide, all those steps should be followed. So here, when you are sending a child in an ambulance, so ensure that the ambulance is having a multi-para monitor. So at least you should be able to monitor the heart rate and respiratory rate and SpO2 during the transport, and with a good alarm system, and also they should be having a good monitoring system. So once you ensure all these things, and each of the member of the team should understand their responsibility. So what is a doctor? So the doctor's role is that he will stabilize a patient before putting in the ambulance, and throughout the journey, the patient needs to be monitored, and in case there is any requirement for an IV line or any drug needs to be administered, then like a anticonvulsant or any sedative needs to be administered, so the doctor needs to take care of that. So the nursing staff has to secure the vascular access, make sure that the tube is in position, and again they have to check that all the medications are available. So they have to look into all the medications, the expiry date, whether the dose is appropriate, whether they are loaded appropriately. So all these things, and also the documents should be sent to all the monitoring documents should be sent to taken care of by the nurse. And we need to have a paramedic who will assist in handing out drugs and equipment and can help, because bag and tube ventilation sometimes for when you will require 2 people. So the paramedic will help the nursing staff or the doctor in bag and tube ventilation or in moving the stretcher and oxygen cylinder. So basically transferring the patient from the pediatric COVID care hospital to a HDU or ICU setup is a teamwork, and it has to be a fully planned and organized work so that nothing untoward happens during the process of transport. So far we have monitored the child well. You have made a right diagnosis that the child needs to be shifted. It is also your responsibility that you hand over the child in a good condition or in a stable condition to the team which is already waiting for you at the HDU or PICU. So over to Dr. Suhas Karche, who will be managing this child in the PICU.
Thank you, madam.
Thank you, ma'am. Thank you, Dr. Revati, for delivering such a wonderful session regarding the management protocol, which includes the diagnostic criteria, investigations, discharge criteria, transfer criteria, as well as the transport criteria of moderate cases of COVID in children. Once again, thank you, ma'am. So now we can move on with the next session by Dr. Suhas Karche. He's working as a pediatric intensivist and assistant professor in the Department of Pediatrics, MGM Institute of Health Sciences, Navi Mumbai. And he's a trained pediatric critical care intensivist at DJ Wadia Hospital for Children. And he was working as a pediatric cardiac intensivist at Sir H.M. Reliance Foundation Hospital, Mumbai. So welcome, sir, for the next session.
Thank you, madam. Dr. Jitendra and Dr. Revati madam has elaborated in detail about managing the mild and moderate cases of the COVID. So severe COVID, when after taking all the transport precautions as explained by Dr. Revati madam, when patient will land up in PICU and HDU, then after that what we have to do, we'll see. But severe COVID percentage, only 1 to 2% of all COVID patients will have a severe COVID infection. So that's why you see the time denoted for severe COVID is smaller, because only 1 to 2% cases of all the COVID patient will have severe COVID. So now when patient of severe COVID-19 infection come to our center and we have to admit that patient, we'll admit that patient either in the pediatric intensive care unit or high dependency unit, depending on the respiratory and cardiac support which patient is required. Basically, if the patient is on invasive ventilation and he is in a shock and is on inotrope, it is better to manage that patient in the pediatric cardiac intensive unit. If patient is having only oxygen requirement, not on a very high inotropic requirement, that patient can be managed in a high
Excuse me,
dependence.
sir.
Hello.
Sir,
Yes.
we cannot see the screen.
Once patient is admitted in PICU and HDU, the first thing what we have to do, we have to screen the every system and we have to assess what is the affection of all system. So first we'll send a CBC because we want to see what are the cell lines are there. Is the white cell line is affected? The platelets are affected. We also would like to know the renal function of the patient because it will help us to choose the drug. If the renal function is affected and patient is having AKI, we will choose the less nephrotoxic drug. We'll have to adjust the renal dosing. We have to adjust the fluid accordingly. So renal function test is very important for us. Then liver function will also like to see with liver function is affected or not. There also the drug which are having a mainly hepatobiliary excretion will not give. The second thing is we'll like to send the inflammatory marker. So it will tell us if the patient is either in the cytokine storm or in the multisystem inflammatory syndrome. So inflammatory markers will be raised. So what are those inflammatory markers? It is CRP, anti-proBNP, procalcitonin, D-dimer, LDH. These are the inflammatory and ferritin. So we'll send those inflammatory markers. We'll see if these inflammatory markers are raised. Next thing is to assess, we want to assess the perfusion. So to assess the perfusion, we'll send ABG. If the BICAV is low on ABG, it will help us to see whether either is patient in a sepsis or the perfusion is affected. Lactate will be high if the perfusion is affected because the anaerobic metabolism will take place. Next is to do a cardiac assessment, and the cardiac assessment will be done by 2D echo, NT-proBNP, ECG and X-ray. So it will tell us about the cardiac contractility, whether the system is full or not, inferior vena cava is full or not, can we push more fluid in it, is there any need of inotrope, all this information will get. So once patient is admitted in PICU labeled as a severe COVID, we have to do this all workup without any delay because each of this information is going to help us ahead in the managing a severe COVID patient. Then next thing we have to do is to optimize the oxygen, and it is done either by giving a respiratory support which is non-invasive, or if non-invasive is not effective, we have to go for an invasive ventilation. Amongst the non-invasive ventilation, we have three options. One is high flow nasal cannula, continuous positive airway pressure, and non-invasive ventilation. Now, each of these have their own advantage and disadvantage. High flow nasal cannula, the disadvantage is it is generally considered as a more aerosol generating procedure. So spread of infection can be more in the ICU and aerosol generation will be high. But the greatest advantage is that it is very well tolerated by the children and there is no claustrophobia. Children are not apprehensive. So it is very well tolerated. On the other hand, CPAP and NIV are less aerosol generating devices than HFNC. But because there is a mask which is covering entire nose and face, the children, they become very apprehensive, very uncooperative, agitated. So they generally do not tolerate CPAP and NIV. So that is the disadvantage. So depending on what kind of kid, either is the older kid to whom we can explain to breathe with the air, we can use NIV. In the smaller kids, if you can become more apprehensive by mask, we can use HFNC. And then if even on HFNC and CPAP NIV patient is desaturating, the oxygen requirement is more, or patient is developing deterioration in sensorium or shock, or there is a carbon dioxide retention on ABG, we will have to move to a invasive ventilation. So The next thing is the proning also has a distinctive advantage, as explained by the Revti madam. Proning, what does proning done? Proning, it normally when patient is lying supine, the alveoli and the dorsal aspect of the lung are collapsed. They are not taking part in the ventilation. When we do the patient in a prone position, those alveoli are opened up and they take part in the ventilation. So we say the lung is recruited. So the total lung capacity is increased and oxygenation increase. Now in children, awake proning is possible more than 6 to 7 years. If the child is more than 6 or 7 year old, if you instruct them, they will lie prone and they will feel better also. But the smaller kids, proning is very difficult. Even patient is on invasive ventilation, the proning is possible. In Western world, they are doing proning, but for that you have to be very, very careful. A team of 6 to 8 person is required for doing proning in an invasive ventilated patient. One person is assigned to take care of the endotracheal tube, because while doing proning, there is a high chance of displacement of endotracheal tubing. Then one person is assigned to take care of central and arterial line if there are any, and other 4 person do the proning. So invasive ventilation proning is a very difficult job. Whether to do it or not, it depends on the manpower which we are having. But yes, awake proning is very much recommended and it should be done. Then restrictive fluid therapy is a standard of care in a COVID. Of course, if patient comes and he is in shock, we have to push boluses till the time perfusion is better and shock is recovered. But once the shock is recovered, or else patient is not in shock, we have to give restricted fluid to a patient. When patient is non-ventilated, he's just on the oxygen or room air, we should give 80% of the daily maintenance fluid calculated by the holiday cigar formula. And if the patient is on ventilator, we should give 2/3 of the restricted fluid on a ventilated patient. So restricted fluid is very important, because more fluid you give, that fluid, because of the capillary leak, is going to ooze in the multiple organs, and that fluid is only going to cause later problem for you. Then in severe COVID, there are very few drugs which are there. The most important drugs is steroid. So all patients who are labeled as a severe COVID, they should immediately receive a steroid, because it is the only drug which has definitely shown to improve survival. The steroid, if not given earlier, should immediately be given. The steroid of choice in children is methylprednisolone, 1 mg per kg per dose. BD is the ideal, or else you can give a dexamethasone 0.15 mg per kg. Next important drug is enoxaparin. Enoxaparin is a low molecular weight heparin. The dose is 1 mg per kg. OD subcutaneously, depending on the D-dimer level, you can titrate the dose, make it BD, so total dose will be 2 mg per kg subcutaneous. So it will, because there is a thrombotic tendency, so enoxaparin will take care of the thrombotic tendency, and sudden events like pulmonary embolism could be avoided, and IV steroid will take care of the cytokine storm. Then antimicrobial are also important, because immunity is at stake. Secondary infections are possible in ICU setup, so antimicrobial should be done. So out of these three don't have any issues, but remdesivir, definitely initially it was included in the adult guideline that remdesivir in a phase of viremia, which lasts for first 7 to 10 days, the remdesivir in a moderate and severe COVID was indicated. But now it is removed from the adult guideline also by the WHO. So in pediatric, we also don't have any safety data. So beyond 10 days, remdesivir definitely have no role in a severe or moderate COVID, but in less than 10 days, the role is controversial and there is no safety profile yet established. Now, the next thing what we have to manage is shock. So shock in a case of severe COVID-19 infection should be managed like any other shock. So if patient comes hypotensive, pulses are poor, no urine output, sensor M is down, we have to give fluid boluses 20 cc per kg fluid, maximum 3 fluid, maximum up to 60 cc per kg we can give. But while pushing the fluid boluses inside, we have to monitor the signs of fluid overload side by side. What are those signs? We have to mark the liver size. We have to see if the liver size is increasing. You have to keep auscultating where there are basal crepitation which are appearing, whether there is a JVP which is increasing. If any point of time while pushing the boluses in, if you observe the signs of fluid overload, we should stop fluid bolus immediately and then start the patient on inotrop. Once you give 40 cc per kg fluid bolus, you can always start on an inotrop. The choice of inotrop will depend on what kind of shock we are dealing. If we are dealing with a compensated shock where the BT blood pressure is maintained but the pulse pressure is narrow, we can start with a dobutamine. But if it is a hypotensive shock or septic shock, the first choice of inotrop is noradrenaline. And depending on that, once the BP is built up and depending on the pulse pressure and peripheral vasoconstriction, we can decide on adding any vasodilators such as milrinone or dobutamine.
Excuse me, sir.
Hello, yes,
Sir, we can see only the first slide. The slides are not moving.
yes, I am discussing on the first slide only.
Okay, okay, sir. Thank you.
Yeah. You can see the last column on the first slide. So we are discussing about the management of shock and ARDS. So we discuss about the shock. The ARDS should be managed by ventilatory settings. ARDS generally we have to give very high PEEP to a patient on ventilator. PEEP means PEEP, peak end expiratory pressure, which normally we set at the level of 5 for normal children, but in ARDS where lung becomes strips, alveoli are non-recruited, we have to give more PEEP. There are recruitment manner to know which is optimal PEEP for that child, and we can set the PEEP for that. We have to look for AKI, we have to see urine output, blood urea, nitrogen, creatinine. If the patient is having acute kidney injury, we have to choose the fluid accordingly, and we have to choose less nephrotoxic drug. If at all we have to give any nephrotoxic drug, we have to do renal adjustment of those nephrotoxic drug depending on the creatine clearance of that child. And there is a formula for creatine clearance which depends on the height and serum creat level of the child. Then as any infection go into HLH, HLH means hemophagocytic lymphohistiocytosis. Any infection can go into HLH. So as we manage any other HLH, we have to manage post-COVID HLH also. So there is a HLH protocol which is available, in which we have to do dexamethasone, we may have to do cyclosporine, so that we should manage the HLH. How to suspect HLH? When there is a bicytopenia, there is involvement of liver function. If you do bone marrow, there will be hemophagocytosis will be seen. So if any such scenario with falling ESR, rising CRP, bicytopenia and liver involvement, we have to suspect the HLH and we have to manage the HLH according to HLH protocol. Myocarditis should be managed like any other myocarditis with inotropic drug and cardiac modeling drug. So now we'll discuss the case 2. A 4-year-old boy has a history of fever since last 3 days. Mother has noticed urticarial rash. Child is irritable. There is tachycardia, which is out of proportionate to the fever. Conjunctival hyperemia, but there is no purulent discharge from the eyes. Mild redness of lips. On examination, liver is 1 centimeter, tender. Father has a history of COVID 2 months ago. So what can this be? Can this be COVID? Yes, as Dr. Jitendra explained, any fever can be COVID. But there is something else in this history which is telling me that this can be something else related to COVID. So can this be something else related to COVID? Yes. What is that something else? When there is a conjunctival hyperemia without any purulent discharge, means there is a non-purulent conjunctival condition. There is a mild redness of the lip, and there is a tachycardia which is out of proportion. This tells me there can be something else, and what that something else is post-COVID MISC. What is MISC? Is multi-system inflammatory syndrome in children. So when to suspect this multi-system inflammatory syndrome in children? When child or any adolescent comes to you with fever more than 3 days, there can be a urticarial rash, bilateral non-purulent conjunctivitis. As you can see in the picture, there is a redness of the sclera, but there is no purulent discharge. Red lips, there can be lip cracking which may be present. inflammation in hands and feet. There can be sometime periungual peeling may be also present, and can be a reactivation of the BCG scar. It is there can be a marked prostration or irritability will be there. MISC children can present with the GI symptom. Most prominent gastrointestinal symptom will be diarrhea, vomiting, and abdominal pain. There will be tachycardia, tachypnea. Tachycardia will be out of proportionate to fever. Generally, every 1 degree rise of fever, there will be increase in the heart rate by 10 degree. But here the tachycardia will be out of proportionate to the fever. There will be tachypnea, urine output will be less, and no other obvious cause of infection. Means you have to rule out all other causes of fever with rash like dengue, leptospira, scrub typhus. You have to rule out bacterial sepsis by sending urine culture, blood culture, and staph and streptococcus shock syndrome. So, and there is a history of COVID-19 or COVID-19 contact in the previous 3 months. But this can be absent because many a time there is a asymptomatic infection in parents. So workup of suspected MISC in HDO. So if you find all these symptoms in a patient of MISC, so how to work up? So step 1, you have to send the basic investigation like CBC, complete blood count, CRP and ESR. These are markers of inflammation will be raised. Albumin will generally be less in a case of multisystem inflammatory syndrome. HGPT and serum creatinine will be rise, and SARS-CoV-2 antibody and RT-PCR. If the absolute lymphocyte count is less than 1000 microliter or platelet less than 1.5 lakh microliter, or there is a elevated erythrocyte segmentation rate and CRP, or albumin is less and SARS-CoV antibody is positive or RT-PCR is positive, then you have to go for a step 2 investigation, which are generally a markers of inflammation or cardiac involvement like X-ray, chest, ECG, 2D echo, NT-proBNP, which will give idea about the cardiac stretching. Troponin T will tell you the myocardial function. Procalcitonin, blood culture, PT-PTT like prothrombin time and partial thromboplastin time, D-dimer, fibrinogen, ferritin, LDH, and triglyceride. So this is if you suspect any child with a multi-system inflammatory syndrome, this stepwise approach should be followed. But at the same time, any other causes which can present like a illness similar to MISC like bacterial sepsis, malaria, dengue, scrub typhus, leptospirosis should also be ruled out by sending those investigations. If the patient is in shock and has life-threatening complication, you don't have to follow this stepwise approach. You can send all the investigation together. So what are the types of presentation of MISC in children? So generally MISC can present in a 3 way. So most mild form is a febrile inflammatory syndrome. So in febrile inflammatory syndrome, there is no major organ involvement like renal function, liver function, taste or hematological system, cardiac involvement won't be there. Patient will just spike the fever. So what treatment we generally give? And paracetamol plus low dose steroid like 1 to 2 milligram per kg per day of prednisolone for 1 to 2 weeks we can give. IV fluid and oxygen as per requirement, and we have to monitor this patient for progression to any systemic involvement. The second presentation is generally seen in younger children. They can present like a Kawasaki disease. So full blown Kawasaki disease like symptoms with cardiac involvement. So what are the Kawasaki disease like symptoms? The same we discussed. There can be a non-purulent conjunctivitis, there can be a conjunctival hyperemia, lip cracking, oral mucositis, BCG reactivation will be there, and child will be irritable. There can be edema over the feet. So Kawasaki disease like symptom, but there will be no shock. The blood pressure will be maintained. What is the treatment of choice is IV immunoglobulin, 2 gram per kg, single dose can be given, or methylprednisolone, 2 milligram per kg, 3 to 5 days. Low molecular weight heparin, 1 mg per kg should be given when indicated when D-dimer are below, right? Followed by a low dose of aspirin, 3 mg per kg. And if patient present, the third category of MISC present with the shock and multiple organ dysfunction. So shock is a predominant presenting symptom. Methylprednisolone 10 milligram per kg per day, once a day for 3 to 5 days, and should be tapered over next 10 to 14 days. Low molecular weight heparin 1 mg per kg subcutaneous BD till the discharge, and IVIG if on PDE4 there is a myocardial dysfunction or there is a coronary involvement. IV immunoglobulin 2 gram per kg single dose followed by aspirin 3 mg per kg should be given. So this is a different presentation of the multisystem inflammatory syndrome and management accordingly. Now, can newborn born to a COVID positive mother develop MIS-C? So first we'll see how they should be managed, what precaution we should take during the delivery. So appropriate PPE kit for mother and staff in the delivery room should be provided. Resuscitate the baby at least 2 meters away from the mother or in another room as per standard, and the resuscitation should be done by standard neonatal resuscitation program guideline. Test the neonate for RT-PCR COVID within 24 hours. There is no need to wait for 48 hours. You can immediately test the baby for RT-PCR COVID within 24 hours. Grooming with the mother if the baby is stable. Mother should wear a mask, should follow hygienic precaution like she should always wash her hands. Before feeding, she should wash her nipple area with the soap and use sanitizer. Can breastfeed the baby after following all this hygienic precaution. If the baby is symptomatic and a respiratory distress, should be sent to NICU. Baby can be discharged along with the mother if asymptomatic, but should be kept under close follow for 2 weeks. And red flag sign like lethargy, fever, irritability, refusal to feed, passing less urine, cold extremity, rash, all these signs should be explained to mother. Now, symptomatic now. Neonate, when MIS-C like feature come in the newborn, it is called as a multisystem inflammatory syndrome in newborn. It is rare but can present in first 2 weeks. As in MIS-C like in children, the presentation can be variable and non-specific. It can be in the form of fever, vomiting, poor feeding, lethargy, rash, fatigue. They can present with a breathing difficulty, tachycardia, can present with a shock and neurological symptoms like seizures. So what we have to do, we have to rule out the sepsis by doing blood culture, urine culture. If there is a convulsion, we have to do the CSF also to rule out the meningitis. And other conditions like prothrombotic conditions should be ruled out. The management of MIS-C in children with the age and weight appropriate drugs. So management should be done like a MIS-C. Only thing in newborn, the weight and age appropriate drug should be chosen. So instead of methylprednisolone, we prefer dexamethasone in newborn, and drug we choose the appropriate doses. The strict precaution during aerosolized procedure and closed ET suctioning. Inline suction should be used in this patient because it will minimize the aerosolization. Prefer CPAP over HFNC because CPAP is a lesser aerosol generating device. Discharge only if the baby is asymptomatic for continuous period of 3 days, active, feeding well, and all vaccinations should be deferred for 4 weeks. Thank you. Now I hand over the session to Dr. Vijay Kamale.
Thank you so much, Dr. Suhas Kharche, for conveying the valuable knowledge on managing the critically ill children with severe COVID-19. And he has explained well regarding the management of children with post-COVID complications like multisystem inflammatory syndrome. Thank you, sir, once again. So now we'll move on to the next session by Dr. Vijay Kamale about the psychological issues in children with COVID-19 and related to COVID-19.
So now I will be taking last session, that is on psychological problems which may occur in children during COVID time. So here we will be having multiple situations. This can be general or COVID related. In general, what I can say is problems can occur because of prolonged lockdown. Lockdown is going for prolonged period. Children are not coming out, they are not playing, they are not mixing with their friends. So they are usually at home, they are learning online, and exercises are not there, said food. So a lot of issues related to COVID in general are happening into the society. Then another problems can come in children. They can be related to COVID situation itself. Suppose if his family member or somebody family is affected by COVID, he gets isolated. Mother gets isolated if she's having COVID or get admitted. There can be death of adult or caring family member into the family because of COVID that can affect the child's psychological health. Or there can be a child with COVID itself, which is requiring isolation. So these are various situations. There may be many more situations which can affect the child's psychological health or mental health. So we have to observe the child psychosocial effects, and we have to ask questions to the parents and as well as child. We have to interact with the child and see or do effective communication with the child and family, and early recognition of psychological markers. So these questions can be asked: that is the child showing increased irritability, anger, frustration on small issues? If that is there, you have to be careful, you have to observant, you have to follow up the child regularly. In a smaller child, it can be asked that is the child clinging to the mother all the time? Because this is happening. They are at home, so they will cling to mother, they will attach to some person only. If mother is busy, they will get attached to the father who is working from home only. Sometimes it may happen that child may show regressive behavior. Usual thumb sucking can be physiological for a certain time, or bed waiting till 5 years can be, but if they are started after stopping thumb sucking or enuresis, they again starting having enuresis, it will be a problematic. Older children, now they are attached to mobile phones, tablet and TV only. Education is on mobile phone or tablet. So, but what happens? There is the extension of phone or tablet use that can happen. TV viewing can be more. So this has to be asked if any psychological alarm is there. Another thing I said, change in diet. During initial 1 year, probably all the children were at home only, eating home food. There were less illness. Especially GI illness were less, but mother is giving a lot of food, so obesity has been a problem, and continuation of same feeding habit is there. Very few children are eating less nowadays. That is the observation. But after opening of long lockdown, in between the first time and second time, they have started eating outside food, and the outside food or junk food related problems have started. Then sleep problem also has to be asked, whether the sleep is good or no, sleep hygiene is good or no. Child is waking up off and on, or child is sleeping during daytime, sleeping late, etc. That has to be asked. Sometimes the children are becoming quiet and they are not showing interest or pleasure in activities or meeting family and friends. Some of the parents are showing when they are coming to doctors or pediatrician, they are telling the child has been brought outside for the first time in last 1 year just to show the doctor because he had some problem. They have not given even for vaccination. This has happened during last 1 year. Older children can show sometimes signs of helplessness or crying spell. That is a sign of depression. So these are the various psychological issues which can happen into the children because of current medico-social problem. So how do you advise in such situation? Is advice is not only for parents, it is for doctors and other workers who are frontline health workers. So for parents, it can be said that they have to spend time interacting with the child. Unfortunately, it has happened that because of work from home culture, a parent or both of the parents are started working at say 8 o'clock in the morning and working till 8 p.m. in the morning. Both of them, lot of stress into the family as far as work culture is going on, or sometimes 10 to 10. Their parents are given leave for half an hour for lunch or breakfast, 15 minutes. That has happened. That is actual thing which is happening. So they are not having time spending with the child. So interaction has become less in certain families. So that has to be changed. Work culture has to be advised to change. Then listen patiently. Avoid offering instant solution. Instant solution, I will give you chocolates or I will give you a toy. This is an instant solution. So that solution should not be there. Or I will take to the, these hotels are closed, but I will take the Swiggy thing from the home for you, order, etc. So these are instant solutions. They should not be followed up. And we have to, as a parents, they have to display affection readily. Scheduling the timetable. As I said, they are working from 8 a.m. to 8 p.m. Then scheduling is very, very important. You have to cooperate with other work members also regarding schedule. So scheduling the members or giving some work to the older children also is important. Like involving children in daily course. Then not only giving ye kaam kar do, we have to appreciate whatever they have done and don't scold if they have done some mistakes, because it is the learning period. They have not done throughout their life probably any work they are. So assistance to mother or a father during daily course and work is very, very important. That has to be told to the parents. Connect them with family and friends through online or media, social media. That also becomes important. Do not focus much on academics, because they are doing academics on online only. So academics is good. This year everybody has passed. Next year I don't know what will be happening. But on academics, they should get involved proactively rather than we have to take this percentage marks and other things. So these are the tips for the advice for the parents. Doctors are also important part in the managing psychological health. So doctors should be available online as well as offline for the parents. What has happened during first 3 to 4 months? Many times doctors were not available offline because of fear, or many old doctors have stopped practice because of all this. So then the changing doctors has also become a problem. So those who have stopped practice, they should be available online for advice, at least free or paid depending upon their wish. Then ask or look for psychosocial symptoms. So each and every child coming to you nowadays, online or offline, we should ask any problem into the family, problem into the behavior of the child. Then answer questions patiently and to the point. This is very, very important. So talk to the child and talk to the parents and answers their questions very, very patiently, so that they get lot of confidence and they can groom their kids very well. Doctors' duty is to give proactively positive messages through various examples. Even if something very bad news has happened to the family, we should give the positive message to the parents as well as the child, so that he will not go into further depression. Then refer in case of symptoms and signs. Referral also is important. You are observing for some time, timely referral is important, and so referral in case of symptoms and signs of prolonged distress or self-harm or severe weight gain or loss, that is also important. Here I will state that MGM, New Bombay College of Nursing, and MGM IHS has already in the process of submitting similar work based on cognitive and behavioral problems in COVID, during COVID. The work is being done, and this work is very, very important work. In past 2 waves, we have observed that psychological counseling was done only from phone, like parents and relatives, etc., morning in MGM. Still, it is done on only phone. Patients are not coming much, but children are coming. And because of children, adults also are suffering. So if you ask the child any problem is there, you can find out the problems in adult also. And I hope best for this endeavor which MGMS college is taking in the field of cognitive behavioral problems and social mental problems. So with that thing, I stop here and give the message that if child is safe, then home is safe. If home is safe, then nation is safe. And if nation is safe, then all the universe will be safe. I thank you for all the participants who have participated in this webinar. Today was the based on module, whatever is scientifically evidence-based module. So I thank MGM College of Nursing and MGM Medical College also, Dean sir, for this thing. And after this, I hand over these proceedings to the Anna. And I think question answer sessions will be there. Anna.
Yes, sir. Thank you so much, sir, for giving valuable information about the psychological issues in children. At the same time, how to promote the psychological well-being in children during COVID-19. Thank you so much, sir. So there is some information for all the participants. We have sent a feedback link regarding to today's session in the chat box. Kindly check your chat box to get the link for the feedback, and we would appreciate if you would complete that and provide your feedback. So please open your chat box and find out the link for the feedback, and please submit the form at the earliest. So, okay, now we are coming to the end of today's session. So this is all about the question and answer session. So we could see so many questions in the chat box. So one by one we can discuss. So I think all the panelists are ready for answering the questions. Can I proceed with it?
Yes, you can proceed.
Okay, sir. So the first question, it has been asked by Mr. Alauddin. Can we give chest physiotherapy to the children? And what about giving a prone position in children if they are completely irritated during hospitalization?
Chest physiotherapy for a children is hello.
Yes, sir.
Is definitely advisable for moderate and severe, and those who know how to carry out the chest physiotherapy. Even in hospitalized patient, as Dr. Revti and Dr. Suhas Kharche said, the prone position and physiotherapy is very important. It should be followed as per the adult guidelines. Physiotherapy and in a proper precautions that probably will be taking this session on tomorrow, how to resuscitation and other measures. So that will be talked at that time.
Okay, sir. Thank you.
Dr.
so much.
Suhas, any answer?
Physiotherapy is definitely recommended for patients who are having a respiratory compromise. Means any patient who is on long-term ventilation, having a difficulty in clearing a secretion, physiotherapy is definitely advisable. Chest physiotherapy in children should be, we just have to tell the physiotherapist which lobe of lung is more involved, and depending on that they will carry out a particular maneuver to drain the secretion from that lobe. And the neurophysiotherapy may be required in a patient who is on a long-term ventilation, so that to avoid the chances of diffuse atrophy. So chest physiotherapy and neurophysiotherapy both will be required.
Okay, thank you so much, sir. So as sir has mentioned, it is very mandatory if a child is critically ill and admitted in PICU and in a long-term ventilation. Okay, so we can go to the next question, which was raised by Ms. Usha Menon.
This is regarding the administration of remdesivir injection. So they are asking like whether it is safe for children or is it beneficial for children or not.
Dr. Jitendra,
Can I take it?
yeah.
Yeah. So as far as remdesivir is concerned, the studies are primarily not done in children, and whatever data we are having is an extrapolation of the adult publications. And over a period of time, the many publications are coming. One major study was carried out was a solidarity trial, which included 25 countries across the globe, and the results are not that encouraging. So over a period of time, in newer and newer versions, WHO has reduced its recommended reduced use of it, and ICMR also has accepted reduced use of remdesivir. So probably we'll come to a point where remdesivir will not be used at all. But on compassionate ground, sometimes we may have to compel. It cannot be a recommendation to use, but as Dr. Suhas and Dr. Revti said, case to case basis, we may have to use sometimes, because it has got a EUA authorization, emergency use authorization. It's not like that you have used and someone will sue you. It's not like that. So it is definitely used as small as newborn also, but definitely there is a evidence emerging that its role is questionable.
Okay, sir. So regarding the remdesivir, still the studies are going on. Yet we need to get a clear idea about it. But as per the recommendations, still we are recommending the remdesivir injections to the children. So that's about the remdesivir question. And one more question we have. This is about the requirement of wearing the mask in children. So at what age we can recommend the children to wear the mask?
Yeah, again a good question. The use of mask as such is not going to come in any of the activity of a child. So ideal recommendation, although is above 5 years, as big as 2-year-old and beyond also can definitely use a normal mask, homebound mask, definitely, and there is no contraindication for use. And once you inculcate this habit of using the mask appropriately in children, then definitely we have seen last year there were hardly any influenza cases or swine flu cases. Even the incidence of open tuberculosis had come down. So all these advantages are there, but physiologically there is no contraindication that less than 5 years should not use, but the ministry recommends it beyond 5 years only.
Okay, sir. So
Those children who are cooperating with mask, less than 5 years, we can use mask, because we have seen
Yes.
many kids are there on their own, because this is a learned behavior. They have learned behavior. Everybody is using mask. They have started using mask. Many of the smaller children also, and they are faithfully they are carrying that activity while going out. That is our objective. So it is better to teach them how to wear the mask by self explanations or self example, and then they will wear. It is better for them, even if for smaller children.
Okay, sir. Thank you so much. So it is recommended that the children can wear the mask after 5 years, but if they want to wear the mask after 5 years, we have to inculcate that habit at least from
Before
2 years
5 years.
onwards.
Before 5 years.
So 2 year onwards at least. So because they are in a phase of imitation, okay, they will copy whatever the parents are doing. So this is the best time during the toddlerhood. You can you can teach the children to wear the mask properly, so that it can be as a part of their daily life. Thank you so much. So I think our questions got over. So
I can see one question in question answer forum. Someone has asked whether breastfeeding transmits the infection. So the answer is absolutely no. Breastfeeding is in fact advisable in COVID positive mother as well, who is physically fit to breastfeed, but with the proper precautions, like mother is wearing the mask and washing her hands frequently, and she can breastfeed without any doubt of transmitting the infection into the baby. So breastfeeding is in fact advisable.
So we need to promote the breastfeeding even during the COVID-19 pandemic. That will add benefits to the baby. Thank you, everyone.
One more question, I think in Q&A I can see about the alternative pathy. So the answer is big no for any of the non-proven medications. In fact, even in allopathy, most of the medications are not proven to be used in COVID. So only paracetamol, nutrition, good hydration, and monitoring, intense monitoring. These are the major methods to give a good outcome. Not just Ayurvedic medicines, but even in allopathics, the rampant use of ivermectins and doxycyclines and other masala we should avoid.
One more thing about steam inhalation. Many adults are taking steam inhalation. They are forcing the children also for the steam inhalation. That can sometimes dangerous also for the smaller kids. And we have observed many burns sort of or scars patients which are coming up all on the face also, or if the spillage is there on other parts also. So that steam inhalation, no study has been done. So it should not be morning, evening. That should not be advised. That also should be told to the patient at home, especially if they are adding something into it that can be dangerous.
Okay, sir.
Someone has asked about the nutrition in
Yes,
COVID.
yes.
That will be answered, I think, in detail tomorrow.
Okay. So related to the diet, in detail, we have a session on tomorrow, so you all can attend the session. I think all the questions got over.
Yeah, I think Dr. Vijay Khamale and Dr. Jitendra, this was a successful webinar for today, and all the sessions were very informative, and you were very simple, and what day-to-day problems will arise when the children come to the hospital or at home, you have explained. All the sessions were done very well, and it was very simplified, and I think everyone must have understood so many things, and maybe visualizing what more can be done when these children come to the hospital. And it was an excellent webinar for today, and we are looking forward for tomorrow. And I think those children who come to the hospital and we do their assessment for their cognitive, developmental, and all other areas of the development will also be very useful in assessing these children in future. Thank you very much for all your support for today's webinar.
Thank you very much, madam.
Thank you, madam.
Thank you.
Thank you, ma'am. I think we can wind up this session today, and we can continue the session on tomorrow. Okay, this general reminder once again regarding the feedback.
Feedback has to be given immediately or afterwards, so can be given
The earliest.
Earliest. No.
Those who are giving feedback only will be given the certificates.
I request all the panelists to come on the screen so that we can picture can be taken, image can. So see you all tomorrow once again at sharp 2 p.m. for the tomorrow session.
Thank you, Anna. Thank you, Preeti, and your team. Thank you very much.